When 15 million people lose coverage, and there's over $1 trillion in federal money being pulled out of our healthcare delivery system, that does impact employers and impacts access, it impacts affordability. And I think that's the bottom line of HR 1, is that it is just this massive cut to the healthcare system that we've really never seen.
Healthcare in America isn't just complex, it's chaos, with the information and power stacked against employers and patients. On Margin of Care, we set out to rebalance that scale. On this episode, we are talking to Patricia Boozang, Senior Managing Director at industry titan Manatt Health. Patty has spent the last 25 years working at the intersection and the occasional collision of public policy and private business. She's one of the smartest people on emerging policy and how it will impact employers. And Patty and I will be deep diving into a piece of legislation that is going to send waves through every single aspect of healthcare. HR 1, or as it's more widely known, the One Big Beautiful Bill. HR 1 represents, without exaggeration, a seismic shift in the care landscape, and there is no one more equipped to navigate this new reality than our guest today. What does all of this mean for businesses who are out there trying to protect employee health and well-being?
Yeah, thank you so much for having me. I'm really happy to be here with you. And I think the way to think about the One Big Beautiful Bill Act, or HR 1 is the way I'll refer to it, is that from its outset, the provisions with respect to healthcare and with respect to Medicaid and ACA marketplaces in particular were really aimed at repealing the ACA by another name. And so the result of that is significant policy changes to the Medicaid program, particularly for the adult expansion group. The Affordable Care Act expanded Medicaid, or gave states the option to expand Medicaid to a large new swath of low-income adults. 41 states took that option up. So that's where a lot of those Medicaid provisions are focused. Those are going to result, according to CBO and Manatt's own modeling, in close to 9 million people losing coverage over the next 10 years, becoming ineligible or losing their Medicaid coverage. And I'm happy to talk about what the specific Medicaid proposals were. What was talked about a little bit less, Medicaid really had the spotlight during the budget reconciliation negotiations. It was the big money saver, but there's also significant changes in HR 1 to the ACA marketplaces that are going to result in over 2 million people losing their coverage or becoming uninsured as a result of those changes. And that's before you even consider sort of what's happening now in Congress, or not happening now in Congress, related to the marketplaces, where there's this debate about whether to extend the expanded tax subsidies. And if those go away, which they're expected to, that'll be another over 4 million people who lose marketplace coverage.
All right, so I'm just doing some quick math here. There was 9, there was 2, another 4. So we're talking, 15 plus million people. So how do you sort of think about that affecting the private sector? You've got all of these people that didn't have coverage that now have coverage. They're going to be losing coverage again. What does that do to the private sector in your mind?
Well, when 15 million people lose coverage, it affects the whole healthcare delivery system and the whole insurance coverage rubric we have in our country. Employers can expect to see cost shifting as premiums in the ACA marketplaces go up, because what you're going to be left with is a sicker risk pool of people who must have insurance, so they're willing to pay the increased premiums in the individual market. You're going to see much less funding in Medicaid. I mean, the sort of parallel to the 15 million people losing coverage is over $1 trillion in federal money being pulled out of our healthcare delivery system. That's coming from providers, hospitals, physician groups, et cetera. And there's going to be a cost shift. Employers are going to see a cost shift to employer-sponsored coverage premiums. So I think that's really the top line takeaway. There are others. I think employers that are employing lower income, lower wage, hourly employees are going to see some of those employees lose their coverage, whether they were getting it through Medicaid or the marketplace. If they weren't getting it through their employer, they're going to see those folks losing their health coverage.
I think about like some of the different provisions that we used to come across within employer-sponsored benefit design. So the concept of, a $2 million lifetime maximum, or cost sharing for preventive care services, a number of things that I think most folks back when ACA was passed actually appreciated, that some of these provisions actually, were legislated out of employer-sponsored plans. As you sort of think about kind of going back to the future around uninsured and underinsured rates and just sort of the cost pressures that is going to put on the private sector, on employers, do you think that there's any sort of pre-ACA aspects of healthcare that you might anticipate returning?
Well, a lot of those provisions of the law that you're mentioning, the coverage exclusions, the rating, are still the law. Those are still in the ACA and will still apply. I do think that we could see some of the pre-ACA features coming back. I think we could see higher out-of-pocket costs for consumers. I think we could see employers and insurers responding with perhaps limiting their networks. And the Trump administration, Trump 1 and the second Trump administration have been very open to giving states flexibility to have sort of offering lower value insurance, less comprehensive coverage in the market, like limited duration plans, some of the other insurance products that really had been sort of come out of the market more when the ACA was in its full effect. So I do think we could see a return to some of it. I would say on sort of the Medicaid side that a lot of the tools that states had used pre-ACA to expand coverage to more people were through Medicaid. And I think those tools are going to be less available now in this administration and with this law. So I don't think it can just go back to the status quo. I think there are going to be real challenges to grapple with.
So I'm thinking that some of our listeners, whether they're consulting with employers like this, or we actually have, HR folks that are listening in right now, and they're like, I've got this large workforce right now of hourly and low income workers. They might have relied on other types of programs beyond my employer sponsored coverage in the past. What should I be doing proactively right now if I am an employer that has this type of workforce demographic to ensure their health and well-being, once some of these cuts ultimately take effect?
I think there are a couple of things. One of the big policy changes going into effect under HR 1 is it's called a work requirement, which is that people enrolling in Medicaid in certain eligibility groups. So not if you're disabled or if you're pregnant or, if you're a young adult, but if you're an older adult, a working age adult, that you have to demonstrate either that you're working or you're doing community service, or that you're exempt, that there's some reason you can't do those things. And that's a new condition of eligibility in those 41 states that expanded Medicaid. That'll go into effect in 2027. And employers can play a really important role here. I think first to if they're not already providing navigation support or employee support around understanding if you're eligible for Medicaid, around demonstrating whether it's through data that your employer can provide or information as to why you might be exempt, that you have a particular disability, providing that information to their employees. And also perhaps to the state Medicaid agency, getting in touch, especially large employers, getting in touch with the state Medicaid agency and finding out how can we help our employees demonstrate to you that they're working through us. Additionally, there are going to be people who simply lose coverage. Yeah. And as employers think about, what are the employee supports and services they have in place related to employee education, free vaccine programs, things that benefit employers too. Like you don't want to see more out of work days or sick days. You want to have a healthy, resilient workforce. So what can employers do that has a good return on investment for them related to primary and preventive care and employee education, especially when we're in this era of a lot of confusion about vaccines and preventive care and what should you do, what shouldn't you do. Employers have such an important role to play there.
Yeah, there's information overload and a lot of inaccuracies out there right now. And it's like employees and their families need to turn to somebody that they can trust. And ultimately, it's employers that need to be sort of the ones that are carrying that torch.
I had one other thought for employers that I don't want to miss the opportunity to flag, which is, one real challenge. There's a lot of research evidence that real challenge for low-income workers, especially those working hourly or shift work, is the volatility of their schedule. They're being eligible for Medicaid, working enough hours or not, really can come down to one shift, right? One canceled shift or not getting the overtime. So I just think for employers to think about predictability of scheduling to the greatest extent possible, really helping their employees make sure they hit that mark and they don't at the end of a month, because this is a month by month test in many states, they don't end up losing their coverage because they were a couple of hours short.
Oftentimes we're sort of honed in on like the benefits leaders at organizations, but you start to think about sort of the moving pieces here right now around how the benefits team needs to talk to the time off and like the leave teams, and just think about overall workforce strategy to try to optimize the programs that are available. So, you sort of alluded to this too earlier. We've got some of the different changes that have happened or going to be happening as a result of HR1. One of them being the removal or the reduction in subsidies that people have that they can apply towards the public exchange. So, the math would work out that if the subsidies are going to be reduced, that there's going to be fewer people enrolled in those plans. What are your thoughts in terms of how that's going to change the cost and the expense around commercial insurance that employers are going to be having to ultimately bear the brunt of, regardless of whether they're self-funded and sort of budgeting for this out of their own general assets or leaning on, a risk-bearing arrangement with the insurance companies?
Yeah, well, as I said, I think the marketplace changes, the ACA marketplace changes haven't gotten enough attention. And in fact, they're the first to hit, if you will. They are being implemented now. Some were effective on July 4th when the president signed the law. Others have come into effect over the summer and into early next year. The law makes enrollment and renewing your coverage in Medicaid look like it did before the ACA. In other words, the ACA sort of made that look like employer-sponsored coverage. Like you and I, our coverage sort of automatically renews unless we go in and make a change or switch a plan or affirmatively do something. And that's sort of how the marketplaces have worked as well. And the law changes that and says, nope, you've got to come in every year and actively do something to keep your coverage. And that's just going to cause a lot of people to lose coverage. The other thing the law does is that makes ineligible a big swath of people who are immigrants, but who are legal immigrants. They have documentation. They live in our country legally. And they had the ability, if they were paying taxes, because this is a tax credit, right? These ACA subsidies, to take advantage of being able to buy subsidized insurance in the marketplaces. They're also losing that eligibility. And so they're going to lose that coverage. And the impact of those changes, plus the loss of enhanced premium tax credits, which is outside of the law, but certainly related, means that people's premiums are going to go up 11, 12% on average. The CBO and others have estimated that. And they're going to drop their coverage. I mean, that's going to become unaffordable. And it's going to be especially true for younger, working, healthy people who are going to leave that risk pool. And of course, you know how risk pools work. When the younger, healthy people leave, the costs are going to go up for everybody.
We used to call it the adverse selection death spiral back in college. Yeah,
right.
Exactly.
Correct.
Yes. I mean, a lot of this stuff is ultimately going to apply additional cost pressure on employers, which, by the way, like every year we're talking about these unprecedented healthcare trends that employers in the country are facing right now, an average of 10% at this point right now. So it does feel like this is going to continue to probably create some bad news around just the trend that these organizations are facing with their benefit plans on a year-over-year basis, and just reiterate the need for them to have, some strategic discussions and potentially some disruptive discussions around like, what do you do to ultimately create a much more sustainable trend for their benefit programs too. So it seems like that challenge isn't going anywhere.
I agree. It's not. I mean, and I think the other part of the challenge, which we haven't talked directly about, is, the pressures of pulling over $1 trillion in funding out of the healthcare delivery system nationally, away from providers, as well as these other changes that are going to be changing the risk pools. That, as I said, is going to result in some cost shifting to employers. Perhaps significant cost shifting. There's going to be a lot more uncompensated care, people showing up for the most costly care without coverage. And that ends up hitting the people who do have coverage, right? Their premiums and the people who are helping to fund their premiums. Where I do agree with you is that I do think this is a moment where thinking about the status quo and what are our old tricks and tools for responding kind of go out the window. I mean, I think that this is an opportunity, and I would hope that employers are really coming together with insurance, with labor, with the state agencies,
with providers, potentially even.
With providers, absolutely, to try to really think about how are we as a healthcare delivery system, as employers, as like a community, as states, respond to these changes in a way that is going to keep our economy strong, but is also going to keep our employees healthy, and their families and the people who, go to school with our kids. And it's a really important moment.
Yeah. Keeping, regional health systems or very rural health systems, afloat too, in instances where they are potentially going to be having all this uncompensated care that they weren't accounting for just a couple of years ago too. So
absolutely,
it really does feel like there's this new paradigm that is going to really affect employer strategy. And I love the idea of like a multi-stakeholder, multifaceted conversation where you bring everybody in across the table. And I think this actually creates an even bigger sort of imperative that those discussions start to happen if they haven't been as well.
Right, because our healthcare delivery system wasn't like it was this strong, robust, like it was fragile going into this moment.
Pretty broken already,
pretty broken already. And the fact is that nobody should feel secure in, well, I don't have Medicaid, that's not me, or I don't have marketplace coverage, that's not me. That amount of money and that amount of coverage coming out of the system really weakens the delivery system. And that does in fact impact employers and impacts access, it impacts affordability. And I think that's the bottom line of HR1, is that it is just this massive cut to the healthcare system that we've really never seen to this level.
Yeah. And ultimately, you don't want to dissuade organizations, patients, et cetera, from accessing the type of care that they need before it is too late. So like services that ultimately help prevent, the downstream cost expenses that are going to ultimately be catastrophic. It's not really getting to the root cause, which from our perspective is there's a lot of quality differences across the country, and higher costs does not mean higher quality. And how do we ultimately help people get to higher quality care so that downstream, the episodic impact on the cost for the system entirely is not going to be problematic. So I do think it misses the ball on a lot of the root causes right now.
It does.
So years ago, pre-ACA, we were talking to employers about these supplemental products to help as sort of stopgaps. So employers were sort of forced into raising deductibles probably more than they were comfortable doing in terms of putting more onus onto the backs of employees and their families, and potentially putting some people in some pretty bad financial scenarios if they had some sort of a major medical need. Do you anticipate that more employers and more employees are going to have to start really kind of dusting off the concept of these supplemental insurance plans to sort of leverage those as stopgaps for coverage that continues to potentially decline or disappear because of just the cost pressure that employers are feeling as they're sponsoring these plans?
I would hope that we could move to more of a place of innovation where we think about value-based payment mechanisms, paying for quality that we can bring into these arrangements, or their direct contracting arrangements, or their differential cost sharing for preventive care, which already happen. But, what is the sort of new innovation, and wrapping around, as we were talking about earlier, employee education. I hope we can move beyond the old models, because that's not a solution for shifting the affordability problem to consumers is not the answer, right?
Yeah, and I would say also taking, and this is another conversation for another day, but taking advantage of technology and AI and just the ways that all can be leveraged to help sort of
I think that's true.
Complement or accelerate some of the stuff that we're talking about too, right?
Yeah, digital health in a few ways, both in the delivery of healthcare, but also in the administration of healthcare. How can we make these insurance products easier and less administratively costly for providers to participate in? How can we standardize more? How can you make credentialing easier? How can you make enrollment in the program easier? How can you make the way utilization management and other administrative functions work more easily? And AI is a really important part of that conversation. And I think the Trump administration is sort of focused in that area too. They're very focused on digital and tech solutions.
I want to maybe just close on just sort of the theme around geographies and how ultimately, again, we've got advisors and employers that are working through accessibility challenges, so as it is getting people to the care that they need within a reasonable amount of time and, finding doctors that have availability, et cetera. When you sort of think about HR1 and how it sort of exacerbates the geographic issues right now and how that impacts employers, if some of these hospitals or these providers have to close up shop due to some of the healthcare cost cuts, and how should employers be thinking about that right now?
I think that's a big fear, right? And if you think about geography, there are three sort of buckets. I'm sure there are more than three, but there are three that I think about. One is the Medicaid coverage losses and cuts are disproportionately impacting those states that expanded Medicaid. So that's 41 states. So there's going to be real volatility there in terms of Medicaid funding flowing into those states. In the non-expansion states, interestingly, they're going to be harder hit by these marketplace changes we've been talking about, right? Because they didn't have Medicaid sort of picking up that lower income working population. Yeah. Medicaid's taken it in other states. That population was going into the marketplaces in marketplace states. And their coverage is going to be much less affordable. We're going to see big coverage losses there. And then the third area that I think about are the rural parts of the country. There is this Rural Health Transformation Fund that was passed as part of HR1. It's $50 billion that's going to go out to states. It doesn't nearly come close to filling the gap on the $1.2 trillion. But those are the areas of the country that are really going to be at risk of losing their providers. And that's where digital solutions, telehealth, hub and spoke partnerships, which is something else employers could really, I think, promote through this is what we want to see happen in our state. These academic medical centers or urban centers that can become partners to rural providers and rural communities. I think all of that is going to require innovation and a really strong role and voice among employers.
This was extremely helpful foresight and insight, Patty. So thank you so much for kind of talking about how this is going to be shifting healthcare from a landscape perspective. The impact of HR1 really kind of reminds us just how closely tied that policy decisions are to the everyday realities that these employers are facing, and importantly, what their employees and what their families are facing too in the broader healthcare ecosystem, providers, et cetera. So I just really want to thank you again for sharing your expertise. It's a lot of fun, and I learned a whole lot, and I think the audience will as well.
Well, thank you so much. I'm really so happy to be your guest today. And I just remember early in my career, someone saying to me, in healthcare, if the employers don't care about it, it won't get done. It won't get solved. So this is a moment where we really need the employers to be focused internally, but also externally on problem solving.
If you're liking the conversation, be sure to subscribe so you don't miss future episodes. And if you've been enjoying Margin of Care, please leave us a review on Apple, Spotify, or wherever you listen. If you've got feedback or questions or something you'd like us to cover on the show, send us a note anytime at marginofcare@getgarner.com. We'd love to hear from you.